Welcome and thank you for tuning in to Derm Docs powered by LiveDerm. This episode, Management of Atopic Dermatitis with JAK Inhibitors, a Pediatric to Geriatric Perspective, features board-certified dermatologists, Dr. Christopher Bunick and Dr. Karan Lal.
Hello, I'm Dr. Christopher Bunick, Associate Professor of Dermatology at the Yale School of Medicine. And I'm here with a friend and colleague, Dr. Karan Lal, to talk about JAK inhibitors used topically from pediatric to geriatrics. Dr. Lal, can you please introduce yourself?
Yeah, thank you for having me. My name is Dr. Karan Lal. I'm a board-certified pediatric dermatologist as well as a fellowship-trained cosmetic dermatologist, practicing both in Scottsdale, Arizona and in New York.
Excellent. Let's dive right in. There's no better topic to talk about than JAK inhibitors. Let's start kind of at the big picture. What is the importance of JAK-STAT signaling in atopic dermatitis pathophysiology? How do you view it or talk to your patients about it?
Well, I think, when we talk about JAK-STAT signaling, I really talk about, inter and intracellular signaling. I think initially in the AD space, we were lucky and we had a lot of therapeutic targets that were very specific towards specific cytokines. And I love that JAK inhibition and JAK-STAT pathways are involved in the mediation of all of the different cytokines that are involved in the pathophysiology of AD. So I talk to people as it being a very specific focused area in treating patients with AD that really doesn't target just one specific cytokine, but really focuses on the broad inflammatory cascade that's involved in atopic dermatitis.
Absolutely. And you hit on a big word, inflammation, right? We have inflammation in the skin in AD. It compromises the skin barrier, which drives more inflammation, and controlling all those cytokines becomes very important. You mentioned some of those cytokines, IL-4, IL-13, IL-31, TSLP. A lot of those cytokines also play a key role in itch. And in your practice, especially in the pediatric group, as well as adolescents and adults, how important is itch in atopic dermatitis quality of life?
Well, I think, we often see in kids, there's either two categories. It's the kids that look really bad and we know are itchy, even though they can't describe it. I think that's the hardest part when we assess parents and we ask them about itch. I kind of feel stupid sometimes saying, is your child itchy? And they're like, well, no. And I'm like, really? Because they look like they're doing something. They're squirming or they're arching their head back and they're making these movements, which I think if you're not someone that's attuned to that, may not know that these are children that are itching or feel itchy and they're maneuvering their body to get that itch happening. So I think, and it's hard for parents to assess that. So sometimes I have to be very in tune and looking at children to see how they're acting or behaving. And then obviously, I think a good surrogate marker for itch is sleep. I think when there's poor sleep, it's often relative to or secondary to itch. And sometimes kids don't have to look that bad, but we know that there are kids that have just this filaggrin mutation that despite having a lot of clinical disease, feel very itchy because of their barrier defect. And so sometimes these kids get undertreated and we focus just on barrier support, not knowing that, when you have a barrier issue, you still have sensory neuronal hyperreactivity that is involved in itch. And so it becomes very important to address that even in those kids that don't look that bad, but have that sensation of itch.
I totally agree with everything you just said. One of the most impactful pieces of data that's changed how I treat atopic dermatitis patients is understanding how critical itch is to quality of life. In adolescents and adults, what we find is just going from an itch score on that 11-point scale, 0 to 10, just going from a 1 to a 2 or a 1 to 2 or 3 can, in the quality of life measures, actually cause 40, 50, 60% drop in quality of life in that population. And when I saw that data, it just really emphasizes why recommendations the AHEAD task force recommendations for managing atopic dermatitis are really looking at combined or composite skin and itch endpoints in order to achieve what's called optimal treatment targets or minimal disease activity. It's the new standard of care. And JAK inhibitors are really able to push that boundary of standard of care. And I think that you mentioned why that intracellular signaling gets right home to the point, right, of the action of the signaling cascade. So with that said, how do you envision JAK inhibition fitting into the future of dermatology?
I mean, I think it's interesting to learn that the JAK pathway is involved in so many different diseases, whether it's atopic dermatitis, whether it's vitiligo, whether it's hidradenitis. I think we're just starting to learn really the association of this pathway and a lot of these other chronic inflammatory diseases, which is great because once we have these targets, alopecia areata, we can use drugs to our advantage and treat people that have multiple comorbidities or multiple conditions, and find drugs that have multiple indications because of this communal link. And I think it also goes to prove that it makes sense why some of these diseases like atopic dermatitis, vitiligo go hand in hand, alopecia areata, where we know that there is some association between these diseases, partly because they share this, inflammatory cascade or component that is similar, having a similar immune signature to some degree in these disease states.
When we think about the treatment in your case, particularly the pediatric population, what role does corticosteroids play in your practice versus actually parents who are asking for non-steroidals? We know that there's a big push in dermatology right now for non-steroidal topical use. And how do you envision this JAK inhibitor kind of wave in dermatology being able to reduce the unwanted use or the excessive use of corticosteroids?
I think that, for us in dermatology, we often forget that, topical steroids were like a huge innovation and contribute so vastly to our field. I mean, we use them, I think, to treat 80% of the inflammatory diseases that we treat in our clinic. So I'm not poo-pooing topical steroids. And in fact, the conversation really should be how to use topical steroids safely. And we know that topical steroids, when used appropriately in the acute setting, are extremely helpful. The problem is people often don't know how to taper these medications or switch to appropriate medications that can be used safely long-term. And for conditions that are chronic, like AD, in many patients that we see, because we have a bias, right? We see people that have diseases for longer standing periods of time, as opposed to pediatricians and primary care doctors that see the acute cases, and in the majority of patients that just self-resolve. I think for us, it's always looking for the safest option for people long-term. Do I have patients that have inappropriately used topical steroids for 4 weeks and develop stretch marks in the axilla? Absolutely. Do I have patients that have inappropriately used topical steroids for short bursts of time and become chronically addicted, and they use it for their short periods, not having a maintenance proactive routine, or haven't had access to non-steroidal topicals and had developed topical steroid withdrawal because they just start and stop? Do I have patients that develop tachyphylaxis to topical steroids and don't know that tachyphylaxis is an immediate phenomenon, not a slow-going phenomenon? Of course. So I think because of all of these things, the evolving landscape has to be that we have to focus on chronic disease management and safety, and that comes with the use of non-steroidal topicals. I don't think that we're ever going to get rid of topical steroids, and I don't think we need to, but I think what we need to do is make sure that we have an appropriate maintenance routine. And I think part of JAK inhibition also becomes disease modifying. We know that patients that receive oral JAK inhibitors, to some degree have a pretty good improvement in their AD, and they can start and stop the use of these medications because they get really good symptom improvement with a remission for a period of time, and they're able to restart. So in my practice, where I think before we used to use oral steroids for AD very selectively, or even drugs like cyclosporin, now we have oral JAK inhibitors. And the reality is topical JAK inhibitors have phenomenal quick itch onset data as well. So to have something that has efficacy for itch just as good as an oral that works pretty quickly, I think changes the game and is going to allow us to use medications more effectively in a more disease-modifying fashion. What do you think?
I think you hit the nail on the head on a number of things. Importantly, you're absolutely right. Topical JAK inhibitors have very good, not only inflammatory disease control, but itch control. And part of that stems back to what you said earlier about broad cytokine inhibition. Well, it's able to also hit IL-31, which is thought to be one of the more important itch cytokines. Certainly there's others, but it's able to hit IL-31, IL-13, TSLP. So that's really important for that itch. And I believe that there's data even showing within 15 minutes onset of itch relief with topical ruxolitinib, which is incredibly profound for patients. I also like how you talked about oral JAK inhibitors, because oral JAK inhibitors plus topical JAK inhibitors, they work by the same mechanism. So that makes it easy as for us as providers to educate our patients. They're working on the same proteins, just one orally, one through a topical mechanism. But topically, being able to use a topical allows precision delivery to the skin and hopefully avoids unwanted systemic exposure. And I think that that's an advantage to using the topicals. In the pediatric population, I think one of the things that really becomes important for parents is to feel that they're able to use that medicine safely for a long period of time. I like what you said about the topical corticosteroids acutely only, but atopic dermatitis is a chronic disease. Whether you're a kid, an adolescent, or an adult, the truth is you're probably needing a topical for a longer period of time. And up until just the last couple of days, we've only had a topical JAK inhibitor approved for atopic dermatitis in the adolescent and adult population. But I'm very excited, Dr. Lal, to announce that we now have topical ruxolitinib approved in the pediatric population between ages of 2 and up to 12 or younger. This is an incredible advancement. And how do you think this new indication in this age group is going to impact your practice?
I think potentially we're going to, we have in terms of, I will just say in the biologic space, we have indications for some drugs down to 6 months of age. In the oral space, we have drugs down to 12 years of age. And we have this window where, from 2 to 12, are there patients that may not need a biologic anymore because we have access to a drug that is so targeted and has such age data for a certain body surface area? For a while we were limited when people, have refractory itch, even if they have mild disease, that we were putting them on biologics, which is fine and great, and we love biologics, but if we can provide something that's a topical that people can feel safe about using and know how to use very well without worrying about side effects that are associated with topical steroids, I think we've hit the game. I think we're going to have a lot of kids that normally would have been put on a biologic because they were in no man's land. They were only in the land of biologics because they were younger than age 12 and they have, mild disease, but that's chronic and refractory. And so they're, we're putting them on biologics. And so now we have something that I think is going to be a saving grace and may allow us to either delay the need or even potentially prevent the need or use of biologics in these mild patients that just have chronic refractory itch and disease.
As a reminder for all our listeners out there, we are focused in on the phase 3 efficacy and safety data of topical ruxolitinib in its new indication for pediatric atopic dermatitis for patients aged 2 years and older. Let me give the big picture here. So we had 330 children, and they were randomized to vehicle, about 65 patients, or to 2 different doses of ruxolitinib cream, the 0.75% cream, which was 134 children, or the 1.5 ruxolitinib cream, which was 131 children. The primary endpoint was at week 8, looking at the number of patients that significantly achieved an IGA treatment success, which was considered either clear or almost clear skin at week 8. And secondary endpoint would be at week 8, EASI-75 response. Ultimately, as said, the ages of the children were 2 to 11 or less than 12. And what's really important about this age population is in the broader United States, there's about 2 to 3 million patients with atopic dermatitis in this age bracket. That's the impact of this study. The body surface area for the children in this study was between 3 and 20%. Ultimately, what was the take-home data? Well, the primary endpoint, IGA treatment success at week 8, basically 56.5, we'll round it up, 57% of the children getting the ruxolitinib 1.5% cream twice daily actually achieved this endpoint. That's pretty remarkable. That's basically over half of the patients are achieving treatment success in just 8 weeks, whereas they were not having that success with placebo. So what's the delta with placebo? It was around 47%, 47%. That's how good this cream beat vehicle was by literally almost 47%. When we look at EASI-75 measure, 67% of the children hit EASI 75 on the 1.5% ruxolitinib cream. And EASI 90, Dr. Lal, when have you heard EASI 90 being used for a topical in the pediatric population?
Never. Usually EASI 75, EASI 50. Those are the typical, I think we're now hitting that psoriatic marker with these topicals. It's the new benchmark is much higher, which is great.
So EASI 90, take a guess how many children hit EASI 90 at week 8 on the 1.5 ruxolitinib cream?
You want to take a guess?
Take 10%. A guess. 44%. Can you believe that?
No, I mean, that's
4%. That is remarkable. Now, we've been talking about itch. 43% of people or children had 4-point or more improvement in itch on that particular 1.5% ruxolitinib cream. I think that this data is incredibly powerful, and it speaks to everything you've been saying. So with that data, how do you envision topical ruxolitinib impacting treatment of atopic dermatitis in the 2 to 11-year-old age bracket?
I mean, I think it's going to be a game changer, because in the real world, in a study environment, sometimes things don't even perform as well as they do in the real world, because there are so many other factors, right? We don't talk about the, barrier control, barrier repair, moisturized emollients, all of which is the standard of care. And so I think in the real world, I'm expecting even higher outcomes. And I think that just for someone who suffers with AD, myself, who's used this drug before, and even though we speak for this drug, it's an amazing formulation. And I think we have to remember, for kids, the old classic teaching is you have to use the ointment, because the ointment's not only going to provide a therapeutic outcome, but it's also a barrier. And we know that part of the disease is a barrier. And I think we're changing the way that also is, we're changing the way that thought process, that old school where you need to use a thick ointment. Kids don't want to put a thick ointment. I don't want to put a thick ointment. Elegance, to me, in my practice, leads to compliance. The better the product feels, the more likely they are to use it. And so not only is there clinical efficacy, but I think the vehicle in itself and the way it feels kids don't feel ick or gross after using it, which is a very important thing to consider. You can give people the best product in the world, but if it doesn't feel good and they don't want to use it, they're not going to use it.
Yeah, I agree with that. And to sort of kind of combine our earlier discussion about topical corticosteroids with biologics, well, it turns out the efficacy that we just reviewed and discussed puts ruxolitinib, it has the benefits of a topical corticosteroid in terms of that broad efficacy, but without the risks of chronic use of steroids. But it also has biologic-like level efficacy with that 44% EASI 90 response at week 8. Those are numbers that are biologic-like. I think that this bodes well for children. But anytime you have a study and we talk efficacy, we also have to talk safety. And Dr. Lal, what does it mean to you if I say that there were no new safety signals, that this was as safe in the pediatric population as it is in the adolescent and the adult and the geriatric population, not just in atopic dermatitis, but even in vitiligo? What does that say to you, no new safety signals?
Well, for me, it says a lot, but the reality is, when I talk about safety in children, it's very different. We often have to forget we're dealing with a relatively healthy patient population. We're not dealing with people that are often associated with polypharmacy that have a lot of comorbidities. So with kids, we can get away with doing much more. And I'm often more aggressive with my kids than I am in my adults. So it bodes well to me, because I was never concerned with the adverse events profile anyway in adults and the adolescent population. So for me, it doesn't change much in my practice, because it's something I would do anyway if I had access to it in this age population. So I think it just reinstates the fact that this is something that is safe for kids to use. And we worry about, children and having increased body surface area, potentially more absorption, and to know that that did not correlate with an increased amount of different or serious adverse events is huge.
Yeah, I like what you just said about systemic absorption, because really the reality is we want to try to minimize systemic absorption when you're developing a topical. How do you feel that ruxolitinib, it gives you that flexibility to treat when and where you want to benefit the patient, or in this case, the child? How does that flexibility play into your thinking as a clinician, and really that aspect of trying to maximize the efficacy to safety ratio when you're treating your population of pediatric patients?
When it comes the conversation I often have is these are kids that, like I said, for me, it's going to change my game for people that I probably will be able to hopefully avoid and delay a biologic. And when you commit to medications like a biologic, which like I said, are prefacing great medications, the discussion I often have is, well, how long is my child going to be on this for? And it becomes a routine thing. When you have kids and you're able to control their disease with a topical like this, and people become used to managing these flares in a more effective way with the use of a drug like this that has efficacy, safety, and elegance, I think that that's going to be very important, because I think people, and part of it is, I think a lot of people do a disservice and they say, here, you're going to use this medicine twice a day, and then you're going to, to all these affected areas. I think that that's where we need to be better about education. And I think that's what separates me from a lot of other people. I talk about, when you have a flare, you want to use this medication twice a day until you're clear. Now, we don't have label data to say what to do after a patient's clear, but we know from a number of other studies with other topicals that proactive therapy, using it twice a week, can be beneficial in reducing potentially the amount of flares. So proactive therapy and flexibility is huge. So if I'm going to have a bunch of people that are going to want to use this when things are bad and want to let go and then go back to using their moisturizer, and will use the drug more frequently when they flare again. But I truly think, and I hope for a day where we can get proactive data, because I think that, like I said, because of the chronicity of this disease, having that flexibility and using something even a little bit twice a week in a pulsed fashion, I truly think clinically does correlate to a reduction in number of flares. I also think the other thing that I deal with is a lot of kids that are skin of color. That atopic derm disproportionately affects, darker skin patients and, people in lower socioeconomic status. So I think for me, another interesting thing that I want to mention is I've noticed, even just anecdotally in the adolescent population, that my kids that have atopic derm, when they use topical steroids, their inflammation gets better, but they do get prolonged hypopigmentation and even peripheral hypopigmentation. And that can be frustrating. And sometimes that's more frustrating than the disease process itself. So I've noticed just in general that pigmentation repigments faster with the use of a medication like ruxolitinib, because we do know that there is some intrinsic effect of JAK inhibition on repigmentation and melanocyte activity. So I think, again, reminding that dyspigmentation sometimes in pediatric patients is more alarming for parents, and there are phenotypes of atopic derm that present with hypopigmentation, and those can, those particularly can be benefited from a medication like this.
Absolutely. Dyspigmentation, whether hypo or hyper, is incredibly upsetting to patients of all ages, children, adolescents, adults. And the reality is we don't have a lot of good ways to correct the pigment. And I think that anything that can help, such as the topical JAK inhibitor, certainly needs to be considered in patients that are experiencing that. So we've talked about switching the paradigm, kind of after a short burst of topical corticosteroids, utilizing a topical JAK inhibitor. But what about topical calcineurin inhibitors? Do you use those in your pediatric population with AD? And how do you see this new indication of topical ruxolitinib for pediatric patients with AD changing the usage of topical calcineurin inhibitors?
I think overall the trend is going to be that these topical calcineurin inhibitors are going to over time be used less and less. Now, unfortunately, insurance companies sometimes require the use of these two medications to get access to another nonsteroidal. So by virtue, we have to use these sometimes. I don't think that we understand the strength of these nonsteroidal topicals. I mean, we kind of assume that tacrolimus 0.1 is equivalent in potency to a medium potency topical steroid, and tacrolimus 0.03 and pimecrolimus are low potency. That's what we have access to. And the tacrolimus comes in an ointment formulation. It does sting for many people upon application. There is some photosensitivity involved with tacrolimus and the development of even, photofreckling that can occur. And then people use pimecrolimus, particularly in sensitive areas like the face, in a cream formulation. I just noticed that a lot of these things we use them to buy time. I think a lot of us are using them to buy time, and it makes us feel better. And sometimes we have to, because we're concerned about prolonged topical steroid use and adverse events. So we kind of give it as like a break, and I think we assume on the vehicle of these drugs sometimes to be more of the helpful component, right? We're giving tacrolimus as, it's an ointment. It'll provide some barrier support. Maybe it'll do something. It'll buy us some time. give us a break from topical steroids. That's really, if you want me to be honest, that's probably the reality of the situation. We just don't think about it. So I think having something that's actually effective, that is elegant, that does not sting, that has activity, efficacy, and safety is going to completely change the way that these nonsteroidals behave in the pediatric and adult population.
And something that just came to my mind while you were talking is just in children. When we think about some of those special areas, whether it's the face or the hands. Now, in this particular study, the scalp wasn't studied, but when we think about the face, the hands, the genitals, skin folds, just having the ability to use something with that efficacy and safety you just described and not have to worry about some of the side effects of the traditional topical therapies, especially the steroids, is incredibly important. We've touched on this just slightly, but I want to just reiterate the question. What is the benefit of starting a topical JAK inhibitor therapy as early as possible?
I say time is itch. So the goal is to get itch relief as quick as possible. And to my knowledge, I do think that JAK inhibitors topically and orally do that the best. And so for me, their use in the immediate period is truly to get people more comfortable, because if they're more comfortable, they will be scratching less and they will be propagating the disease much less. So I think the speed really comes down to getting improvement of symptoms, which in transit and in translation over time will, result in better clinical efficacy. What do you think?
Well, I agree. Stopping that itch scratch cycle is so important. Number one, when you stop the itching, you improve sleep in the children. I still believe that leads to improved quality of life, school functioning, activities of daily living, and then that also perpetuates into decreased inflammation, which then leads to decrease throughout that entire cycle. And one of the things that we've been kind of dancing around with the whole topical versus biologic space is that topical JAK inhibitors are not your typical topical. They are designed to be monotherapy, not use the steroid with a biologic or use this with something else. The JAK inhibitors, particularly ruxolitinib, is a standalone monotherapy that's able to hit the inflammation, the itch, and with a high safety profile. And I think that's what makes this particular product unique amongst all the treatment options in atopic dermatitis.
Yeah, I mean, I couldn't say it any better. And I think, again, the role in these, I think we also know the permeability and the efficacy of ruxolitinib in the skin. Like, we know how well it is absorbed into the skin and how it's, transcutaneous absorption is what leads to its efficacy in both disease states. In fact, I've even heard that topically ruxolitinib performs better than, even just when you talk about vitiligo, anecdotally, the topical rux works much faster than oral JAK inhibitors. So I think that, to me, in someone that has a barrier issue, translates to better permeability, which means faster onset, which means better outcomes.
One issue that dermatologists just really do not like to talk about is access. But in reality, over the last several years, both in treating atopic dermatitis as well as vitiligo, topical ruxolitinib has seen insurance coverage become less of an obstacle. Insurances are covering more access to this particular medicine for patients, I think because they realize how transformative this medicine is in terms of both AD and in terms of vitiligo, really being the only JAK inhibitor in this space, particularly in the pediatric population now in AD. As we conclude our wonderful podcast, it's been a joy having you, Dr. Lal, with me here to talk about all of this. Do you have any final parting words for our listeners to take home about having available topical ruxolitinib, which we've had for adolescents and adults? Now we have it in the pediatric population, age 2 to 11. What do you want our listeners to take home?
I think I want to remind you guys that kids are very great patients to treat. I think a lot of people are afraid of, treating children. I think, it's become very easy to be like, oh, AD, let's do this injection. Let's get the pace going. We have to remind ourselves that just because something is easy doesn't mean it's always the best thing to do. I think we always have to be open to new ideas and open to discussing and having these discussions with parents. Don't just assume when you're talking to parents the decisions that they want to have and the decisions that they may make. I think you need to talk about all the available options. That's what I do when I talk to parents, and I'll say, the options are X, Y, and Z. What do you think aligns with you best? And I talk about the pros and cons and and the adverse events and challenges and access and all of those things. And I would say, this medicine may be hard to get, but I'm going to fight for you to get it. But you have to be on board. I'm not going to go through all this work if this is not something that you're going to follow through with. And I think giving people the ability to try medication in clinic. So if you have access to samples, sometimes I think it sucks giving out people samples because they may not get the drug, but at least having them try and feel what that itch relief feels like in 15 minutes during the whole time of your visit. The other thing is, I know you primarily treat adult patients. What has your experience been with ruxolitinib in the adult population thus far? And how do you think that this will change how you practice?
Well, I think that's a great question. So in moderate severe AD in adults, I tend to go to the systemic therapies, advanced systemic therapies early and often. I do believe that there's a benefit in shutting down that systemic inflammation. One of the parallels that I like to describe, we've talked about in the pediatric population, how systemic inflammation can impact growth as well as bone mineralization. But that systemic inflammation on the elderly side or geriatric side, I think is also at play. And that's why AD patients that are not on an advanced systemic therapy, patients with moderate severe AD off therapy, have higher rates of MACE, VTE, and malignancy. And actually what we're seeing with agents like oral systemic JAK inhibitors is that the rates of AD patients on therapy for MACE, VTE, and malignancy are actually equal or lower than the background rates off therapy. And why might that be? Well, it's because these agents may be decreasing the systemic inflammation. And so I think there's a logical connection between what we're observing in the pediatric population and the older adult and geriatric population when it comes to decreasing the systemic inflammation in moderate severe AD. Now, where do I use topical ruxolitinib? I think that what we commonly are doing is when we have a patient on a systemic therapy, we often need a topical to supplement for those small flares that can still occur, right? When we think about, we talked about EZ90 response. Well, the reality is in our adult populations, we're not hitting EZ90 as much as we need to with many of our therapies, particularly the biologics that sort of have a ceiling, at least in the network meta-analyses, somewhere around 40% response rate for EZ90 achievement with the current biologics in our network meta-analyses. So that means there's room for improvement. There's a lot of room for improvement. And one of the ways that we're helping those patients that aren't hitting EZ100 is by supplementing with a topical. So in my practice, topical ruxolitinib is a wonderful option. I've gotten it approved through insurance for people that are on biologics, and I think that it works very well. So one of the things that we want to do is try to limit those systemic corticosteroids, and as we talked about, limit the chronic use of topical corticosteroids. And I think that topical ruxolitinib does a good job of fitting now these guidelines that are coming out, trying to not eliminate steroids altogether, but limit them to acute flares and transition quickly to advanced topical or advanced systemic therapies when appropriate.
I 100% agree. And so I am so excited that we have this innovation, and I can't wait to try it. And I would love to hear how other people, and their success stories, but I'm sure stay tuned. We're all in the learning space, and it's only going to get better.
All right. And with that, Dr. Lal, thank you for joining me, and thank you for this Live Derm podcast.
Thank you for having me.
Stay tuned to Derm Docs, powered by Live Derm, for more dermatology education coming to you soon.